Hello, welcome to the Walrus Talks at Home Pharmacare, generously supported by the National Association of Federal Retirees. I'm Jennifer Hollett. I am the Executive Director of the Walrus, and we are thrilled to be joining you online in conversation, bringing together people from across the country and beyond. I'd like to start by acknowledging the land that I'm on right now in Toronto, Ontario, Toronto. A land acknowledgement helps us recognize history and thinking about how it informs where we are now and what changes can be made going forward in a commitment to reconciliation. Our offices at the Walrus, and also where I am right now at home, are located within the bounds of Treaty 13, signed with Mississaugas of the Credit. This land is also the traditional territory of the Anishinaabe, the Haudenosaunee, and the Wendat peoples. And today, Toronto is home to many diverse First Nations, Inuit, and Métis peoples. And thinking about this, we are honored to contribute to a tradition of storytelling. And we welcome you to take a moment to pause and reflect on the land that you're on right now, wherever you are joining us from today, depending on your time zone. And as part of that ongoing work of reconciliation, if you haven't done so already, or even recently, we encourage you to read the 94 calls to action recommended by the Truth and Reconciliation Commission, and we'll post that link right now in chat. A bit about the Walrus. The Walrus is committed to being a platform for Canada's conversation, challenging, urgent, complex, and thoughtful conversations. And we do this in a number of different ways. We're best known for our journalism, available in print. This is our cover story for May, the promise of $10 childcare, but also online at thewalrus.ca. Through our podcasts, our latest podcast is called The Deep Dive, and in our event series like this one. And this work is powered by our donors, our supporters, and our partners. So thank you all for being here and being a part of this, and to the National Association of Federal Retirees for making this conversation possible. Now I'd like to welcome Anthony Pizzino, who is the CEO of the National Association of Federal Retirees. Hi, Anthony, how are you?
I am well, thank you. Thanks for the introduction. And I'm pleased to be joining you this evening from the east coast of the country in Mi'kma'ki, the traditional and unceded territory of the Mi'kmaq people, and I acknowledge them as past, present, and future caretakers of this land. The National Association of Federal Retirees is the largest national advocacy organization that represents active and retired members of the Federal Public Service, the Canadian Armed Forces, RCMP, and retired federally appointed judges, as well as their partners and survivors. And on behalf of our more than 165,000 members from coast to coast to coast, Federal Retirees is delighted to be sponsoring this evening's event with the Walrus. Federal Retirees has advocated for improvements to the financial security, health, and well-being of our members and all Canadians for nearly 60 years. We are nonpartisan, and collectively, our members believe in good public policy to ensure every Canadian today and in the future benefits from better retirement security and a strong, sustainable healthcare system. Service to others is the highest calling. Members of federal retirees have spent their working lives in service to Canada, and our members and volunteers continue to serve by giving their time to ensuring that their peers and future retirees can enjoy a secure and dignified retirement. Canada is the only country in the world with a universal healthcare system that does not provide a universal prescription drug coverage, and we believe that that must change. And that change is not only possible, but achievable. We are looking forward to contributing to thought leadership and debate on this important issue with tonight's guests, and to edging Canada closer to a more affordable, accessible, and consistent approach to drug coverage for all Canadians. Our health depends on it. Jennifer, back to you to introduce our contributors and get this very important event underway.
Thank you so much, Anthony Pizzino. And I love the commitment to good public policy. That's really what shapes our country. Tonight's talks explore our current system of prescription drug coverage across Canada, as well as what might be on the horizon. As mentioned, right now, Canada is the only country in the world with a universal healthcare system that doesn't provide universal prescription drug coverage, which really doesn't add up when you think about the original vision for universal healthcare. And this lack of coverage impacts a lot: our economy, healthcare, long-term care, and the everyday lives of so many people. The way I look at it is it's really just such a basic need. If you think of someone who's sick and requires medicine, they should be able to get it. COVID-19 has highlighted many flaws in our systems. And with the federal government's recent partnership and commitment to developing the Canada Pharmacare Act, what are the key considerations for moving toward a more affordable, accessible, and consistent prescription drug program? Here's how tonight works. Each speaker has 5 minutes. And once we hear from our talkers and your head is full of new ideas, we'll have a moderated Q&A session with our speakers and you, our audience at home. So we encourage you to submit your questions at any point throughout this event. You can put it in the Zoom chat, or if you're watching on Facebook Live, hello, add it to the comments section, and we'll try to get it to as many as possible. We also encourage you to share this conversation on social media. Take a picture of how you're watching us tonight, wherever you are in Canada or in the world, or just take the moments or the learnings or things that jump out, and you can share that on Facebook or Twitter. Tag us at the Walrus or use the hashtag Walrus Talks. Tonight, we'll be hearing from Dr. Steve Morgan, who is a professor at the School of Population and Public Health at the University of British Columbia. As well, Linda Silas, President, Canadian Federation of Nurses Unions. Dr. Durhane Wong-Rieger, President and CEO of the Canadian Organization for Rare Disorders. And Dr. Samir Sinha, Director of Health Policy Research at the National Institution on Aging. Thank you all for joining us, and we'll kick things off tonight with Steve Morgan. Welcome, Steve.
Hello, as I will introduce, my name is Steve Morgan, and I've been studying pharmaceutical policies for nearly 30 years. I really believe that this conversation we're having tonight is very important because national pharmacare systems can provide universal access to appropriately prescribed, affordably priced, and equitably financed medicines. Indeed, they do so in every high-income country with universal healthcare because every such country integrates prescription drug coverage and management into their universal healthcare system. Well, every such country with the exception of Canada, that is. Despite all of our pride in Canadian Medicare, it is uniquely incomplete insofar as it effectively ends as soon as a patient is handed a prescription to fill. Our current pharmacare system in Canada is not a system at all. It is an incomplete and uncoordinated patchwork of drug plans. This patchwork consists of over 100 different public drug plans. These vary significantly across provinces and across the patient groups that they target. Our patchwork also includes tens of thousands of independently financed and independently managed private drug plans for the roughly 2/3 of Canadian workers who are lucky enough to have such coverage through their workplace. The coverage offered through this patchwork of private and public plans is hardly uniform, and it is certainly not universal. Nearly 1 in 4 Canadians is uninsured for prescriptions or underinsured for the medications they need. This often occurs because when Canadians are lucky enough to have coverage, their drug plans require them to pay hundreds or even thousands of dollars per year out of pocket. Inadequate prescription coverage affects Canadians in all provinces, at all income levels, and with all kinds of health needs. This results in well-documented barriers to necessary care across Canada. Indeed, it is estimated that more than 2 million Canadians are skipping prescriptions because they cannot afford the out-of-pocket costs. That results in worse health outcomes for patients and higher costs elsewhere in our healthcare system. It would be far better for our health and for our healthcare system just to provide universal, comprehensive public coverage of necessary medicines, just like we cover medical and hospital care in Canada. It turns out that doing so would also be cheaper. You see, Canada's patchwork of independently financed and managed drug plans is not only terribly inefficient to administer, it also fragments our purchasing power on the world market for pharmaceuticals. Research has shown that single-payer pharmacare systems, like the ones found in Australia, New Zealand, Norway, Sweden, and the United Kingdom, use their purchasing power to obtain the best drug prices in the world. Now, presently, the prices of prescription drugs in Canada are among the highest in the world. But if we implemented a truly universal pharmacare system, it would be one of the biggest bulk purchasers of medicines on earth. And as anyone who shops at Costco knows, prices fall when you buy in bulk. And it's not just me who's saying this. The Parliamentary Budget Officer and the Department of Finance have both estimated that the purchasing power of a national pharmacare program would be so significant that a comprehensive public pharmacare plan for all Canadians would actually cost us $4 billion a year less than we are currently paying for medications through our patchwork of private and public drug plans. Now, I want you to remember that. A comprehensive public pharmacare system built just like Canadian Medicare will save us billions of dollars per year while improving access to medicines from coast to coast to coast. National Pharmacare can also ensure that the best available evidence guides all of our decisions concerning drug coverage, drug pricing, and prescribing and utilization. This is why 5 separate national commissions have recommended that medically necessary prescription drugs be integrated into the Canadian Medicare system. This is also why it is just so important that the federal government fulfill its promise to implement national pharmacare without further delay. A principled and evidence-based pharmacare system for all Canadians will immediately improve healthcare across this country. It will save lives, and it will save billions of dollars every year. The only real obstacle to getting this done is the opposition of industries who profit from the status quo. And that is why conversations like this one we are having today are just so important. These conversations mobilize people, and in so doing, they generate the political will that is necessary for government to do the right thing for Canadians, even in the face of industry opposition. So thank you. Thank you for listening and for being part of this conversation.
Bonjour, everyone. I'm Linda Silas. I'm national president for the Canadian Federation of Nurses Union, and I'm calling tonight from New Brunswick, the beautiful land of the Mi'kmaq people. So first of all, a big merci for bringing up this important topic, this important social discussion, or as Anthony said, a good public policy. As you heard Dr. Morgan talk, he's been researching this for 30 years. Well, I think I've been lobbying for this for probably 20 plus years. A national pharmacare program is not only key for sick Canadians and their family, but for every healthcare administrator that is out there trying to find money to fund primary health care, long-term care, home care, and acute care. All our healthcare system are in dire need for funding, and we look at the waste we are doing without a national pharmacare program. Nurses, like many other healthcare workers who gets their hand dirty in our healthcare system, have recognized for 20 plus years that we needed a national system for our prescription drugs. What we're doing is dangerous and wasting money. And how can we continue justifying cutbacks in healthcare when we know that we're in some situation just wasting funding for prescription drugs or not funding them properly? We know that a lot of patients are either in hospitals because they can't afford the prescription drug, not taking them properly, or the price of prescription drug is going up and up and up, not only for us as citizens, but for our healthcare system as all. As Dr. Morgan said, we need a system that will not only bulk buy like the Costco model, but look at the best practices across the world and how can we better do it in Canada. You heard Dr. Morgan talk about savings. You know, is it 4 billion? Is it 7 billion? Some even say it goes up to 11 billion There's many economists looking at a national pharmacare program. Regardless if it's 4 billion or 7 billion, it's a lot of zeros and a lot of taxpayer dollars that could be put into our healthcare system in a better way. And how do we support it? When we talk about access and barriers to prescription drugs, it is more than the big cancer treatments, and that's what comes to mind often. But we need to talk about preventive care. All those high blood pressure prescription drugs that will not eliminate, but reduce risk of strokes, of heart attacks. Of course, that brings you to hospitalization, or the asthma puffers for children that will stop them from being hospitalized instead of going to schools. That's why we need a national pharmacare program. It's for prevention of chronic disease, but also looking at the big cancer and the rare disease, as you will hear from another speaker in a minute. Also, we're talking about access and barriers. Some would define it as diagnosis or treatment. That's our whole primary health care. We need to improve our primary health care, and that's more doctors, more nurse practitioners into a system. But let's be real. If a nurse practitioner or a doctor prescribes you your needed medication and it's on a piece of paper, but it's only a piece of paper if you don't have access to get the prescription drug that's needed, that means you don't have the means to pay for it. I remember the good old days when I worked in the emergency departments where we were able to give sandwiches to those who were hungry and samples to those who needed it. It is very hard to do that today, and only some physicians are lucky enough to do it on certain cases, but this is not how we should be funding our healthcare system through samples. We need to do better. We talk a lot about half-truths in Canada. Most, for example, our healthcare system is very modern, or most workers are covered for prescription drugs. No, 60% of workers are covered with some kind of prescription drug. It's a mishmash. You heard Dr. Morgan talked about, some say close to 100,000 different private plans with different rules. And if you change employment, your rules are changing, and often they're just decreased. Public plan is the same thing. I'm in New Brunswick right now, different plan than PI or Ontario or BC. And you have to think twice before you move if you're 65 or if you have a chronic disease. It's all about a high cost and equality of coverage. And on top of that, during the pandemic, we looked at the workforce. Twice the numbers of workers lost their coverage compared to those who got coverage through a private insurance. So we have to look at it there. Now, our healthcare system is modern. That's another half truth. There's not even links between most prescribers, physician or nurse practitioner, the pharmacy, and the patients. And never mind the best practices, because that's the way of saving money in the system on the best practices for the drugs. So we need to put all of that into one circle and make it better. What I'm reminded every day is we're a large country, but we're small in population, 37 million. California has more population than we have in our whole country. So with 37 million people, we have to learn to work together and have social programs that will help all of us. Merci, thank you.
I am Durhane Wong-Rieger, and I am President and CEO of the Canadian Organization for Rare Disorders. And just to put a little context in, I'm also Chair of Rare Diseases International, which is our global alliance of patient organizations. And relevant to this discussion, I sit as co-chair of what is now the ERDIC RDI WHO-sponsored working group on global access to essential medicines for rare diseases. So just for, I think that Linda mentioned, for rare diseases are those that quite frankly affect very small numbers by their very definition, some of them fewer than 1 in 2,000, some of them fewer than 1 in a million. And as you might imagine, it's very hard to do research and to develop therapies for such a small population. not only because we don't actually know a lot about the diseases sometimes, but because it's also hard to do the clinical trials when you've got few patients and the patients may be spread around the world. In fact, that's why, with up to 7,000 rare diseases, there are approved therapies for only about 5% of those diseases. And this is actually a big step up from what it was a number of years ago. And the impact, though, on patients, of course, is severe. Many of these diseases are severe, they're progressive, they are life-threatening. About 2/3 of them affect children. About 50% of those children will not live to see their 5th birthday. Things really began to turn around in the 1980s when the US passed the Orphan Drug Act, and in 2000 when the European Union also passed orphan drug legislation to actually stimulate research and to bring these drugs to completion. So today we have about 600 or so approved therapies. The sad news is that actually these drugs don't get to very many rare disease patients. In developed countries like ours, US, only about 10% of the patients who could benefit from these therapies and are indicated for these therapies actually get access. Globally, less than 1%. And the biggest barrier is actually not cost, because in the essential medicines that we have been researching, some of them are older drugs, they're generic drugs, they're repurposed drugs. The problem is, in fact, the lack of a rare disease system. There's a lack of infrastructure that appropriately can diagnose, refer, and actually treat these patients. Even in Canada, which has one of the very best healthcare systems in the world, rare disease patients often get lost. It takes 5 to 7 years to get an accurate diagnosis. Many of these patients are not only misdiagnosed, but they're given the wrong treatments, which in some cases can actually make their disease much worse. And in many cases, they may not get to a specialist who knows there's a treatment available and then is not able to treat them, sometimes not in time to prevent disability or to actually even prevent death. So this is one of the biggest challenges we've got. As you can imagine, in Canada, we were thrilled in 2019 when the federal government, really after Dr. Hoskins announced the Pharmacare program at the same time, put forth a proposal and a commitment to set up a national rare disease drug strategy, committing $500 million a year. We in the court have been working feverishly for the last 2 years to actually host the consultations, bring the clinical community together, bring researchers together, engage the health policymakers, and certainly the industry to come up with what we will hope will be a consensus proposal on how to get these therapies to the right people in order to get them treated. The things we really want to call for is a bit of what Linda suggested, and that is we need to invest in infrastructure, not use the monies to pay for drugs, but to use the monies to develop timely, accurate diagnosis, to be able to have trained clinicians to set up rare disease centers as they have around the world, but not in Canada, and to actually put in place a monitoring program so that when patients are prescribed these drugs, a lot of time with a lot of uncertainty in terms of how well they're going to work because they've only been tested on small numbers. And we need to make them available because we can prevent death or disability, but we need to have ongoing monitoring to be able to collect the information, evaluate the drugs in real time, and make adjustments in terms of how well they're working. We believe that a national strategy where all funders, all payers come together is essential because it will, in fact, allow for us to have what we've been talking about, and that is the ability to command certainly equity in terms of access, but also be able to negotiate for the very best prices. We are very committed to bringing in these therapies in a way to ensure that the right patients get the drugs, that we can monitor these and we can return that information, improve their quality of life through other kinds of supports, and also ensure that this is going to be an affordable, sustainable program. So thank you very much.
So good evening, everyone. My name is Samir Sinha, and I'm a geriatrician. I'm a doctor that specializes in the care of older adults. And I'm speaking today from Toronto, or also known as the Dish with One Spoon territory. So why is a geriatrician here? Well, I represent, or I want to represent, many of our older Canadians, and people would say, well, what's the matter with them? Because, right, they're pretty much covered with medication plans. That the lucky thing is that if you are 65 and older, there's probably a provincial plan that gives you near universal coverage. So what's the challenge, and why should they be thinking about a pharmacare conversation? Because as Dr. Morgan and my colleagues have already talked about, is that we have a patchwork system that doesn't even serve older Canadians very well. Now, right now, 18% of Canadians are 65 and better, as I like to say. And by 2031, when our baby boomers start turning 85, 1 in 4 Canadians will be 65 and older. But we also know that nearly all older Canadians are living at least with 1 or more chronic conditions, and therefore happen to be taking at least 1 or more medications. We also know that when it starts coming to medication use, we know that right now, 25% of older Canadians who are 65 and better may be taking 10 or more prescriptions. And so when they're taking these prescriptions, that's great because it says that there's a lot of access being given to older Canadians. But the challenge that we have is that with access also comes the challenge of making sure that people are being appropriately prescribed the medications that they're on. And one challenge we have is that while most older Canadians have access to a number of medications, not necessarily universal access to all the medications they need, we know that 50% of older Canadians are actually being prescribed 1 or more inappropriate medications, and 18% are being prescribed 2 or more inappropriate medications. And so this is the challenge, that not only do we need to think about how do we better provide universal access to all populations, including older adults, but how do we also make sure that the medications that they're being provided are appropriate? And why? Well, my colleague, Silas, was just speaking about, as a frontline nurse and as for me as a physician, we often see the challenges when people are not being appropriately prescribed their medications. Because we know that right now, 60% of the adverse drug events that we actually see happening in Canada each and every year are happening amongst older adults, who actually represent 60% of the medications that are being provided through public drug programs. But we also know that 40% of these adverse drug events, which could include hospitalizations and potential permanent disability and death, are often preventable. So this is the challenge that we have, is that when we think about the importance of providing universal coverage and universal pharmacare, we want to make sure that we are improving access, and that we want to make sure that all Canadians have access to the appropriate medications, including medications for our older people. But we also want to make sure that there are no barriers to access, because even for older Canadians right now, we know that even a small copayment of $2, $3, $4 often can create enough of a barrier where people who need to be taking medications aren't even taking those medications. So this notion that there's universal coverage and therefore universal access isn't really true. And we know that copayments can be problematic. So we need to think about, how do we not create problems of access for our older Canadians? Again, we need to also think about the appropriateness of the prescribing that we're doing. So we want to make sure that the medications that we are prescribing are appropriate when they're being prescribed, but also we want to make sure that there are processes through which we can actually make sure that we're regularly reviewing a person's medications, maybe annually on their birthday, to make sure are any medications still necessary, or any medications unnecessary, so that we can actually make sure that they're on the right mix of medications they need. And making sure that we enshrine the processes of appropriate prescribing and even de-prescribing, as I like to call it, to all of our prescribers, whether they be nurse prescribers, whether they be pharmacist prescribers, or whether they be physician prescribers as well. And so by thinking about this appropriateness aspect, and by thinking about improving access and affordability, this is how we can think about a sustainable pharmacare system that, as Dr. Morgan talked about, if we actually implement this, we can actually create a much more sustainable and universal model of care that can better support all Canadians as we age. So I'll finish there, and thank you very much. Merci.
Thank you so much, Samir, Sinha. as well as Steve Morgan, Linda Silas, and Durhane Wong-Rieger. All right, we're excited to open up this conversation. To our audience at home, I am loving all your questions. We're going to get to as many as possible, but we also want to know, where are you joining us from today? I'm going to take a look. I see we have audience members joining us from Charlottetown. Hello to Montreal. Hi there, King City, Winnipeg, Whitehorse. Thank you so much for making the time for such an important conversation. And again, if you have a question, you haven't asked it yet, there's still time, just submit it in the comments. I now would like to welcome back our talkers to the stage for our question and answers. I have a few to kick us all off. Nice to see you again. Linda, I'd love to start with you. What do you hear from nurses regarding drugs? What are some of the challenges that patients are facing not being able to afford them and access them? Would love if you can give us a story or two so we can, connect and understand.
It's the fear of not providing the full service. We become nurses, we become doctors to take care of patients, and there's this link missing. And it's sad. It's just plainly sad when you see children with asthma. I gave the example a while ago, but you gave children with asthma and the parents are just crying because they can't afford the puffer that the child needs. We did a study a couple of years ago on the impact of not taking your appropriate medication or not being able to afford it. And with just two diseases, heart disease and diabetes, and between 700 and 1,000 working Canadians die every year because they can't afford their medication just for two diseases. I didn't even know they were calculating that. So that's the heartbreaking. And for nurses, as you know, we go through a real hard time in funding positions. And when employers tell you that there's no more money to hire more nurses, and you know that there are ways, that there are billions of dollars out there we could do better by the bulk buying, by the best practice. So that's my answer for now.
Thank you so much. Steve, who in the population doesn't have coverage right now? I'm thinking social determinants of health here, but if you could tell us more in terms of who has a hard time paying for medication.
It's a great question, and it turns out that lack of comprehensive prescription drug coverage affects people of all ages and incomes. Some provinces, for instance, Ontario, provide pretty comprehensive coverage for people over the age of 65, but many provinces don't, including my home province of British Columbia. All provinces do provide good coverage for people on social assistance, but anything else in the middle there, including some older Canadians in other provinces, really, it depends on your good fortune to have been working in a medium to large organization with a union that negotiated benefits on your behalf if you're going to get access to private insurance. So it's a terrible answer to say, but in fact, it's Canadians of all stripes that actually lack coverage. It does disproportionately affect women, middle to low income earners, and racialized Canadians, but it affects people of all incomes, ages, and backgrounds.
That's super helpful. Thank you. Now, when we say universal public health care, what could this actually look like? Would it be using your health card for prescription drugs? Like, would it be that direct? And then how would provincial governments possibly collaborate with the federal government? Samir, I'd love to hear your thoughts on what it might look like.
Yeah, I think right now, I mean, if you think about some of our public drug coverage programs, we have to realize that we're not talking about something that is not achievable. As we've mentioned right off the top here, we're the only universal healthcare system that doesn't offer this sort of coverage. But right now, for many of my older patients, for example, living in Ontario, if they have, an OHIP card, an Ontario Health Insurance Program card, for example, that's really what they need to show to be able to access their medication. medications. And it really is as simple as that. In terms of, you do have universal coverage, your pharmacist knows what's covered, and you simply can get your prescriptions. The challenge is that we have this constant issue of barriers of co-payments that even can be quite restrictive for my older patients, for example, and we often don't have systems in place to best support kind of the appropriate prescribing habits. But really, there can be key mechanisms that we can build on, and in every province right now. And I think by doing this in a national way, by saying, let's take the best features from our systems, let's make sure that we can make this work. This is not a pie in the sky idea, but it's one that we can actually build and especially learn from other countries that are really leading in terms of many aspects of how to actually administer this efficiently, how to ensure that people can have appropriate access, and making sure that we are also doing appropriate prescribing as well.
Great, thank you. Now, what ideas need to be at the forefront of shaping this new approach so that a new universal public pharmacare system can be effective and sustainable? Durhane, I know you're advocating for rare diseases, and I would assume rare prescriptions and therapies that come with that. So what's top of mind for you?
So what we want to make sure is that we're prescribing the appropriate medicine for the appropriate person. The challenge in many cases, and it's not just in rare diseases, but in many diseases, we're seeing highly targeted therapies. We're seeing second, third, fourth, fifth generation therapies, especially when you start to think about cancer with precision medicines. They're going to be highly targeted, right, to your genotype. We know a lot about breast cancer and BRCAs, and we know that if we can identify kind of what is the cause, the genetic cause in many cases of the disease, we can treat it. So we don't have to have a patient go through many different chemotherapies, go through many other radiation therapies. We can identify the genetic mutation they have and get them the right therapy. That to me would be the target. That's kind of how rare diseases work. 80% of these are genetic. We identify the patient, what is the cause of it? Is there a targeted therapy? Now, there's only 5% of diseases that actually have a therapy, but that's the goal. And to make sure then that the patient can get access to that therapy at the right time. Many of our therapies would be for children, for example. And if we can treat them early on, we diagnose them because we've got a good diagnostic system. We get them to a specialist because we've set up centers of excellence. And then we treat them early. And for spinal muscular atrophy, for instance, children who would have died by the age of 2 or 5 are actually now fully functioning. They can walk, whereas they would have been in a wheelchair by the time they were 5 or 6. So it's really, what's the most effective use of our resources? If we can get the right drug to the right patient, but we have to monitor them. We have to make sure that they're working. I think people talked about adverse effects. And again, we can monitor them for adverse effects. We're saying this for rare disease drugs, but I keep saying this is not a national strategy for rare disease therapies. It is a national strategy for all therapies. We're getting more and more to the point where we can have really highly effective therapies. And what we want to do is in every case, see if we can get them to the right persons at the right times. And also, I think the other thing we never talk about in this country, but other countries do, is I think as Samir was talking about, appropriate prescribing. In other countries, we've seen moves to take medicines off when they are no longer effective. We've seen really good prescribing guidelines. Medicines Australia, the national plan in Australia, has along with it a national medicines policy that actually makes sure that physicians on a regular basis are updated, as well as pharmacists. We need to have, along with pharmacare, we need to have a good program like Australia has that would actually encourage and train on appropriate prescribing, but also would allow us to get rid of, drugs that don't work. So, where does some of this money come from? Part of it comes from no longer having drugs that don't work and not having patients go through 1, 2, 3, 4, 5 ineffective drugs before they get to the right drug.
Thank you. I'd like to bring Samir in. I'd love to learn more about de-prescribing. What does that mean and how does it work?
Well, I think the key is that right now, especially for my patients who are sometimes in their 90s or early hundreds, they'll come to me and they might be on 24 medications. And you're just looking at.
You're not exaggerating.
I'm not exaggerating, right? I mean, every day I'm seeing patients who are on multiple medications. It's partly the reason why they're seeing me. You know, sometimes they have a new primary care provider who says, help, I don't even know where to start. Or the patient just lands into hospital because they've had an adverse event. And we're not even sure, like, why are they being prescribed this? You know, we play a matching game saying, you know, to Durhane's comment, you know, like, do they even have the disease to match this therapy or not? And so often we have to actually spend a lot of time doing what we call pharmacological debridement, as if you're like literally hacking away medications and watching the fog lift away. And it's because, you know, the challenge is that in medical school, or if you're a nurse prescriber or a pharmacist, you know, you're often taught about the indications for medications, you're often prescribing medications, but I was not really taught in medical school how to de-prescribe, or how this idea of appropriate prescribing, the idea of an appropriate medication review to say, are you now currently on the right meds? Are all the medications you're on serving the same purpose? And it's also understanding our physiology changes as we age. So as we get older, our bodies actually change, meaning actually how we tolerate certain medications could be changed, or sometimes we might have illnesses that actually fade with time, which is a good thing, and no longer actually need a drug therapy. So by actually having those basic principles in mind and actually having a process, and some provinces do this better than others. In BC, for example, if you're living in a long-term care home, then it's actually required that a pharmacist and a physician actually review your medications to actually see, are you on appropriate medications? But sometimes we don't actually have those processes in place. And so that's kind of when we start looking at the idea of appropriateness of medications. Why I'm emphasizing this is because you can actually save a heck of a lot of money when you realize that a prescription that just kind of sits with a person, in my case, 10 or 20 years, that they never needed to be on, but it's costing us all as taxpayers a lot of money and actually just making them potentially sick. It's just a waste of money. And potentially, if it lands them in hospital, it can actually be even deadly as well. So that's why we talk about this real importance of not only just saying it's about improving access, but it's also making sure that with access, there's appropriate prescribing and appropriate use. That way we can actually make our precious dollars go that much further and actually create a more sustainable system. So hopefully, you know, that gives a good sense of what we mean by appropriate prescribing, and just some examples of how it plays out in some of my patients as well.
Linda, what ideas do you think need to be at the forefront of this conversation in regards to a universal public pharmacare system that really is in it and successful for the long term?
I think it's action. We need to, as my dear departed father used to say, we need to shit or get off the pot here. We've been talking about this since Medicare was created. And let's look at what the federal government was able to do with childcare. They said to all the provinces and territories, we have a plan, standards, and money. Let's get to it. The last one to sign was Ontario. So we were able to do it because we knew that was the best way to serve Canadians. We know we have the evidence, we have eons of evidence that that's the best way to serve Canadians as a national pharmacare program, but it's the best way to keep our healthcare system sustainable. There's so many questions in your chat, which we'd love to have time to look at all of them, but there are evidence. We're not here for nothing tonight. We're here to talk about sick Canadians, about Canadians who can't afford it, but also those who can afford it. You know, are you receiving the appropriate treatment? Are you followed appropriately? And those are the best practice we talked about. So it's integrating our system from best practice, from bulk buying, and from financing it.
Great. Well, speaking of those audience questions, I'd like to get to a few of them now. We have a couple on this theme, and Steve, I'm going to direct this at you. Deborah asks, how does this benefit retired public servants contributing to the health and dental benefits program? And Brian similarly asks, federal retirees have one of the most generous retirement plans in Canada. Are they okay with accepting less access and longer waits for medicines than they enjoy now? So what does this mean for folks who are already contributing to a plan?
Yeah, well, first of all, one of the questions is based on a false pretense or false premise that this would be less access and slower timelines. Best practices in international pharmacy benefit management is timely delivery of evidence-based coverage for patients based on their needs. Canada can match that without any significant problem. For retirees and for current workers, the issue here is that you're already paying for pharmaceuticals through your extended health benefits. It comes out of your total compensation or the cost of your retiree benefit package. A public program will in fact require government to spend more money because it's going to require the private sector to spend less. Even in taking that into account, we will save more money than it costs government to run this program. So some people say, it's going to require us to pay more taxes. Well, you have to think about it in a different way. You will save more money doing this. And so it's not about how do we finance the roughly $15 billion a year in additional public spending on medicines. It's how do you distribute the $20 to $25 billion a year in savings that Canadians will realize as a consequence. And so for retirees and for union members, your unions have been typically the biggest champions of this because they know that it is better to do this in an equitable and efficient way. And the savings in your retirement and benefit packages can be spent on better dental care, better mental health services, and other things that you could be spending that benefit package money on.
Great, thank you. Samir, the next questions, I'd love to direct them to you. Maureen asks, is the current thinking that pharmacare covers all prescription drugs? And some related questions, Catherine is wondering, would diabetic strips and lancets cost cover? They're about like $100 a month. Would that be possible to cover? Someone else is wondering, would birth control be covered?
Yeah, the key opportunity here is that when we're asking, like, can these basic things that are important to kind of monitor your health and actually help support appropriate prescribing, could these all these things be a part of this? Absolutely. And I think the key is that right now, a lot of people will think that, well, wait a minute, my plan can buy better or maybe I'll get more access, with what I currently have, and therefore it's best to stay put and not actually join a broader plan. The key is that regardless of whatever plan you're in Canada, or we've actually mentioned the name Costco a few times. Actually, here's a fun fact. Costco is not the actual biggest buyer or most powerful buyer of alcohol in the world. It's actually the LCBO. The Liquor Control Board of Ontario is actually the largest buyer and actually gets the best rates in the world because it is the largest buyer. So it just shows that even in Canada, we actually have, Canadian-based organizations that can do this. And right now, you think about countries like Australia or New Zealand that actually pay less for their medications with far fewer people than Canada has altogether. So the key is that all these things can be covered. And to Durhane's point, there's a lot of actual other medications, for example, that we could also cover here, especially when we're talking about by better coverage and by saving money in terms of by buying in bulk. We can also include more things, but we can also get the benefit if we actually tie in other aspects like appropriate prescribing as well, because then you actually don't have the knock-on effects, if you will, of inappropriate hospitalizations or paying for medications that people don't even need to be on in the first place. So there's a lot of ways in which we, by saving money, and by having a more comprehensive approach to this, we can actually provide better coverage, and not just for medications, but sometimes for diabetic testing strips and supplies and other key things that we know would be essential to cover, including things like birth control.
Now,
Jennifer, can I just jump in very quickly on this, because we get asked this a lot about how big would this plan be. The Government of Canada commissioned through the Advisory Council on the implementation of National Pharmacare a very detailed report about how we will build this and what best practices looks like. And what they recommended is that it start with about 100 to 150 medicines in the first year, and that it grow very quickly over 5 years to become a fully comprehensive public pharmacare program that would cover things like test strips and other things that are paired closely with medications in most drug plans across the country. But it will take a bit of time, and that time was designed to allow unions and employers to negotiate changes in their existing private drug plans as the public plan got bigger. It also allows our government to write and sign the best contracts with suppliers to make sure not just that the prices are right, but the quality of drugs being supplied to Canada is high and that the stability of the supply is there so that it's there when Canadians need it. So the answer to how comprehensive is, it would be pretty comprehensive, but the current plan is going to take about 5 years to go from where we are now to where we would want to be.
Thank you. Line in chat writes, I am so impressed by the presenters and their thoughts. Thanks. I have to say the same about this audience. We have so many comments and detailed questions. This is such an engaged group. We only have time for a few more questions, and I do want to get to some from the audience. Back to Costco, David writes, for years I paid $80 a month for a prescription until I found I could buy the same tablets off the shelf in Costco in the US at 40% less. Why can Canada not make many more current prescription drugs similarly available off the shelf? Or I'm also just curious at the cost difference.
I'll quickly weigh in. The licensing thing in terms of what a product is allowed to be sold, whether it's over the counter or prescription only, is a matter of authority for Health Canada. It's also a matter of request by the manufacturer to be which schedule it will be placed on. As for the purchasing, big retailers, Walmart, Costco, and others do buy their over-the-counter medicines and get very good prices. Canada could do the same for prescription medicines. There's been lots of talk about creating more Canadian capacity in manufacturing medicines in this country, and I think the pandemic has highlighted the potential benefits of doing that. But that is a strategy that would be a partnership between government and the private sector, because I don't imagine, at least in the short term, Canada is going to start creating a public drug manufacturer. It's likely to do something in terms of partnering with private industry on that.
Okay, thank you for explaining. Diane wanted to know, what is orphan drug therapy? Durhane, do you want to kind of give a two-liner explainer on that one?
Their orphan drugs are drugs that were not ever developed to completion because it was too expensive or you couldn't get enough patients to complete the clinical trials. So researchers and manufacturers would put them on the shelf. So we often hear people talk about orphan diseases. Diseases are not orphaned. Patients aren't orphaned. It's the drugs. But can I jump in for a quick second there and answer Ian Hilly's question? Because Ian says, how can we have innovation? Because we do know there are many new medicines that continually come in and also have universal healthcare and have affordability. And you were asking before, what country should we take a look at? And I would say, take a look at what the UK is doing. They have a new medicine strategy that says we want to have innovation and access to the best medicines, invite investment in research, invite investment in clinical trials in order for us to create a pharma environment that's actually going to promote new discovery, but also give us then the most affordable medicines. Look at what Australia is doing, the same thing. And I think it's a mistake to think that we can not have the best new medicines or the right medicines and at the same time be able to save costs. I think listening to what Steve says or Samir says, we can apply the cost savings right through it. And what do we want to apply it to? If we have appropriate prescribing, and again, Samir talked about that, right? And that we monitor to make sure the right people are getting access to the right medicines, then we can encourage both innovation and we can assure there's going to be sustainability in our system. I think my biggest fear is that we get so hung up on thinking we need to make this cheaper, we need to make it cheaper, we need to make it cheaper, that we start to say no to medicines that are going to be new, but also to patients who may potentially benefit and not give them a chance to be on the therapy in the same way as we want to make sure they don't get a bad therapy. We want to give them a chance if the therapy could work for them. Just monitor it and make sure you get the results.
Thank you. Our final question, I'm going to ask Linda to take this because quite a few of our audience members asked this, which is, how do we get this rolling? How do we make our politicians at the federal and especially the provincial level buy into pharmacare?
You have over 353 participants. They all have families and friends. It's to talk about it again. We were almost there. Steve explained to you the Hoskin report in 2018, 2019, the Liberal promises in 2019. We were there and then we hit a pandemic. So, now it's bringing back the energy. It is a political decision. Premiers right now, premiers of the province and territories are crying for more funding in healthcare. Healthcare providers are saying, yes, we're behind you, we'll support you, but it needs to be direct funding to help all Canadians, because the number one question is universal access. And universal access to healthcare means universal access to medication. If not, we do not really have a universal Medicare system in this country. So push, push, push.
Yeah, there is a moment right now. Thank you again, Linda Silas, Steve Morgan, Durhane, Wong-Rieger, and Samir Sinha. If you enjoyed today's event, we have more. And we're looking forward to seeing our audience in person again soon. So if you are in Ottawa, please join us at the Walrus Talks on Wednesday, April 27th, or if you're in the Toronto area, on Wednesday, May 11th, for 2 different looks at what's next. This is presented by Concordia University. These events will explore artificial intelligence, sustainability, and the social and political innovations that are shaping our future. I think that's what we were talking about right now. We'll also be live streaming these events, so you can continue to connect with us this way. Check in with us at thewalrus.ca/events. You can see our schedule. You can register for upcoming events that are of interest. We also post videos from all of our talks. So tonight's event, if you want to share it with your friends and family, you can find it in the Walrus Talks video room. Also, keep an eye on your inbox. We're going to send you a follow-up email. The best way to stay in touch with us at the Walrus is to opt into our newsletter, and you won't miss a single event. The Walrus, we like to say we're a unique beast because we're a registered charity that produces award-winning journalism, events, podcasts, and more. And we do this with the support of our community of donors and sponsors. So if you enjoyed this free event tonight, consider making a donation at thewalrus.ca. All gifts of $20 or more will receive a charitable tax receipt. Thanks again to our partner this evening, the National Association of Federal Retirees, for your generous support, and thanks to everyone who attended. As well, thank you to our annual sponsors, Air Canada, Inspire, Labatt Breweries of Canada, Meta and Shaw. Community is really important in these COVID times, and each one of you is a part of the Walrus. Thanks again for tuning in. Merci, miigwech, and have a great evening.